Hey, Jennifer, welcome to the show.
Hi, Brittany. Thanks for having me on.
Oh, it's great to have you on. Are you yourself a genetic counselor?
I am a genetic counselor. I've been a genetic counselor for close to 20 years now.
All right. So quick little side story for my listeners and for you. My first dream job was genetic counseling. And at high school, I knew I loved genetics. I was a blessed little nerdy teenager who knew I loved DNA. And I say blessed because I know a lot of like grown adults today that still don't know what they want to do. I was blessed by knowing I want to do something in DNA. And then in college, I wanted to do a genetic counselor, and I shadowed one for the day. And my experience that day was that the genetic counselor spent their day telling women really sad news. And I was like, I'm still a little emotionally unstable. Like everyone on the show knows, I'm an emotional person. But in college, I like still did not have any tool sets. And so when I saw that the whole day was sad, I was like, I've picked the saddest career in the world. And I had a whole like, what am I going to do? And then I got an internship in a laboratory and the rest is history. But side note, y'all were my first career choice. And I'm excited today to potentially even heal some of my own experience.
Past trauma.
Yeah, this could be a beautiful career too. So it's a fun little side note for you.
Well, I think it's amazing that you knew about genetic counseling in high school. I will say I have 2 teenage girls, and I was allowed to go speak to the high school with my oldest, and was pleasantly surprised that the most of the people there actually were familiar with genetic counseling. I will say that wasn't the experience that I had when I discovered genetic counseling 20 years ago. It was one of those things that most people had never heard of.
Oh yeah, no, I was in high school. I graduated 2009. And so it was kind of at least I could Google it, but when I talked about it, no one really knew what I meant. And I didn't necessarily know what I meant either. I just was like, it's about like talking to people about science. And I like that. And here I am, a podcaster. So that, I guess it kind of worked out. Before we kick into the business and genetic counseling and how that impacts women's health, we first always love to learn a little bit more about our guests. So Jennifer, can you tell us a little bit about your background, where you're from, when did you learn about genetic counseling? How'd you get into it? And how did you end up here at Natera?
Yeah, no, happy to. So I am actually from Texas. I've always lived in Texas. I grew up in Texas. I grew up in a small town in Southeast Texas. Not something where I had familiarity with genetics or genetic counseling, but when I was picking my undergraduate degree, I went to Texas A&M in College Station. Genetics was one of those things that just sounded new and exciting and cool. So I kind of randomly selected that as my major. And once I got into school, realized, similar to your experience in realizing that counseling wasn't a good fit for you, I spent some time in the lab and went, oh no.
Yeah,
this is not for me.
Yeah, you can have that effect on people. Yeah.
And so very quickly tried to pivot and realize, like, okay, what else can I do with that? And like you said, my impression of genetic counseling when I was an undergrad, I was like, this is great, right? I'm going to be able to speak to people about genetics. I don't actually have to hold a pipette, but I can kind of serve as that liaison, right, between regular people and the laboratory. And so that was kind of my draw to it. And so went to get my master's degree in genetic counseling. I went to the University of Texas in Houston. And so after that, after I graduated, I was fortunate enough to get a genetic counseling gig up in Temple, Texas, at a very small rural hospital where I was the only counselor. Got to do a bunch of fun everything, being the only counselor there. So I did prenatal, peds, hereditary cancer, a little bit of adult. I got exposed to IRBs, all that kind of fun stuff in my first job. So it was a great kind of get your feet wet, kind of do all the things job. And then after a couple of years, kind of made the switch over to industry. I went and worked for a company named Genzyme, which is no longer in existence, but at that time was a laboratory. It got purchased by LabCorp eventually after I left. But I worked out at 2 different maternal fetal medicine offices in Austin, meeting with prenatal patients who were being offered genetic testing. Then I decided to have some kids. Had some kids, kind of pivoted to more at a work from home position and started, took a part-time position for a small little startup at that time, which was called Gene Security Network, which fortunately has kind of grown and taken off from there and is where I still work, and we're now named Natera. So I've been there for close over 12 years at this point. So kind of worked out really nicely for me.
Love that story. That's a great story. Well, let's, what is Natera and what is genetic counseling?
Yeah, sure. So Natera is a leader in cell-free DNA testing. So that's where we kind of got our start. At this point, we service different kind of segments of patients. We started off in reproductive, specifically looking at women's health, but now we have testing products in oncology as well as organ health. So we kind of run the gamut of different products that service those different patient populations. And genetic counseling is really it is the process of explaining to people genetic concepts. So really what the counselors do from the laboratory perspective is we service both external, what I would call external clients, as well as internal. So what we do a lot of is speak with clinicians who are considering ordering a genetic test. And so we'll talk with them about, hey, this is what the testing can do, this is what the testing cannot do. And speak with clinicians after they've ordered a test, make sure they understand, again, what are these test results telling me? What are they not telling me? Similarly, we meet with patients and provide that same level of service. Maybe before a test, a patient's going, hey, I really don't understand what this test does. We have counselors that are available to meet with those patients over the phone and kind of go through the ins and outs, the risk, the benefits, the limitations of the testing. And then on the other side of it, if they decide to have a test, run through those results with them, make sure they understand, what is this test actually telling me? What should I think about next? So we get to service those. And obviously we serve some internal purposes as well, looking at just the business side of things, making sure that the voice of the patient is kind of heard internally in the company and kind of play that role as patient advocates within the company as well.
I already feel healed. It sounds so much less traumatic than my one day shadowing that person. They must have been like results day. And so I will
have to say, I mean, there has been a big shift in counseling to a lot of people moving to industry. I think it's kind of been a win-win relationship for the laboratories, simply because they want people to understand the test. And obviously the counselors can do that. But honestly, there is a lot of burnout that happens in genetic counseling in the hospital. So your experience of seeing that happen in real life, that is the experience that wears on a lot of counselors who are meeting with patients day in and day out, that oftentimes it can be very routine, a day. And then when it's different, it can be someone's worst day of their life. Now, obviously, you're trained to break bad news and go through that, but I would be lying to say that doesn't affect you as a human, right? Like every day in and out, kind of dealing with that situation.
Well, so I would say crisis diverted on behalf of myself, because my 20s was a lot of emotional growth, and I don't know if I could have done that with this career, but I'm so grateful for the things that y'all do. Tell us really quickly, what is cell-free DNA, and where does one find DNA that's not in a cell?
Yeah. So basically, when you're thinking about it from a reproductive perspective, one of our tests is something called non-invasive prenatal testing. And what that is on a pregnant patient, we can take some blood and we can isolate pieces of DNA that's floating in the bloodstream, in the pregnant woman or the pregnant person's bloodstream that's floating there. What's happening is you're getting that exchange. If you think about pregnancy, that's happening between the placenta and mom, right? Those fragments are coming from there. So it's placental DNA, right? That's floating in pieces. And what we can do is analyze that and look for certain genetic things. Specifically for NIPT, we're typically looking for chromosome aneuploidies, which means extra or missing entire chromosomes. We can also look for pieces of certain chromosomes that may be extra or missing, and even certain single gene disorders, right? There's certain things that happen brand new in a baby that's at the gene level, a DNA level change, that we can also screen for as well using that same technology. So again, basically fragments of DNA that have been broken off, that are not encapsulated in the cell, that we're able to isolate and sequence in the laboratory.
And the blood is just from her arm?
Yep. Just takes a couple tubes of blood, and we can screen for those things.
I've been learning more about the really deep anatomy and biology of pregnancy and other women's, life cycles. And I learned about how integrated the placenta is with the uterine lining, and that that's really where hemorrhaging happens. Cause I'm always like, hemorrhaging, like women are losing a third of their blood, and something bad is happening. And I'm like, where's all that blood coming from? Like, I don't understand. And so I recently am discovering like, oh, it's because the placenta is so integrated into her uterus that it's almost like it's truly a parasite that is like integrated. And so when that placenta is either dislodged or damaged or something happens, like the access to her entire blood flow is right there. And so I'm assuming that's where these pieces of DNA can kind of traverse into her body. Cause I've always thought that too. How the heck? I thought it was like a little bubble, sterile, like, like how the hell is that DNA getting in the body? But is that the way?
You're absolutely correct. That's the interchange right there, right? It's coming from that connection with the placenta and the uterine lining. And absolutely. And I think it's one of the important things that we as counselors want to make sure people understand as well, that when we're talking about looking at those pieces of DNA, that it is coming from the uterus. And it's one of the main reasons this is called a screening test, is because there can be differences that occur in the DNA of the placenta than what's the baby, even though they all started from the same group of cells. Right? You can have differences that occur between that placenta and the baby. So again, as a screening tool, we can look for these things, but it's always important to understand that a diagnostic test is needed to confirm any screening test result. So we may find an increased risk for Down syndrome, which is an extra copy of chromosome 21. It's extremely important that that patient understand that, hey, there's a chance, right? There's a very good chance this baby may have Down syndrome, but you do need to have confirmation testing either through an amniocentesis or a chorionic villus sampling during the pregnancy, or waiting till after the baby's born and taking a blood sample, but something needs to be done in order to confirm that test result.
That actually leads me to my next question, which is there any other way we can sample the baby? You said amniotic fluid and you said some other really techie things. So
yes.
How are those, what is that part of your offering too? Like what are other biological samples you can get it from?
So when I worked as a prenatal counselor in clinic before NIPT was a thing, it was the main tool that we discussed all the time was the diagnostic testing. I would say that we would offer hormone testing that is not nearly as good as NIPT is today, but we would also talk a lot about diagnostic testing as a first line offering for women who were over 35. And those tests, like you said, amniocentesis is exactly as you said it. It's basically using a needle to go in and take out a little bit of fluid that's from that amniotic sac. So that fluid that the baby is floating in. What that fluid has in it is baby skin cells. And so baby skin cells are floating in that fluid as well. And so you can culture those up in the laboratory, and then you can take a look at the baby's chromosomes. And so in that case, you're looking at those cells that are actually from the baby, and you can tell for sure if there is a chromosome issue that's happening. Similarly, I mentioned, CVS. CVS just a little bit earlier in pregnancy. So amnios are typically done after 15 weeks of pregnancy. A CVS can typically be done as early as 10 weeks up until about 12, sometimes 13 weeks. In that case, you're taking a piece of the placenta off. So you could argue a little bit more invasive, right? Like you're taking a little biopsy and a little chunk there out of the placenta. But those are the differences. Those two tests can give you what we would call a more confirmative test. Amnio, like I said, is for sure the fetal cells.
That's so interesting to hear about, like, okay, it's the skin cells and then you grow them up in the lab and then do further testing. Cause like, I mean, I don't know what I thought. I certainly didn't think the baby was putting its arm out in the belly, like, oh,
take the
needle, like, but I also didn't know what I was thinking. Happened. Is it, and it's accessed through the abdomen of the woman, not through the vagina?
Correct. So for amnios, it's literally just outside the belly. I've heard some people think, oh, it's through my belly button. No, they don't tend to go that route. They just kind of find what they do is it's ultrasound guided. And so they kind of see, hey, where's the baby hanging out? We want to find a little pocket of fluid kind of away from the baby. And so they'll insert a needle in, it's ultrasound guided. They'll again take out a little bit of that fluid. There is a small risk of miscarriage. It's typically much less than 0.5% for most providers who offer that testing. But you are making a hole. right? And so there can be some risk that's associated with that. And I think we're seeing a lot less amnios performed these days because the screening tests are a whole lot better than they used to be. Like I said, when I was first out of school, all we had to offer people were hormone tests as screening tests, which would just look at like things like HCG level, PAP-A, different of these pregnancy hormones, and then try to use those levels to give an estimate as to what your risk could be for certain chromosome issues. It was never looking at DNA or chromosomes. It was simply looking at those hormone levels and kind of giving a best guess. Tests weren't that great. And so a lot of women would end up in my office with high risk screening results. And I'd spend a lot of time talking about amnios. With NIPT, since it's been launched, you're seeing a lot fewer people getting what you could arguably say is a false positive from a screening test. They can still happen, but it doesn't happen as often. So you've seen a decrease in the number of diagnostic tests like amnios that have been performed over the years because the screening tests have gotten a lot better.
Well, I can't wait to see what another 10, 20 years can provide us.
Absolutely.
No, I've gone away from our questions, but these are some really basic questions that I think our listeners are really going to enjoy these responses to. Does every woman get these tests when she's pregnant, or when do women have to get these types of tests?
Yeah, so every woman should be offered these tests as part of their pregnancy. So you should be offered, if you're pregnant, screening test options as well as diagnostic testing options. So the American College of Obstetrics and Gynecology has said, hey, everybody can do this. It used to be that we would only offer diagnostic testing to women who are over 35. That's not true anymore. Anyone who's pregnant has this option to do screening test and or diagnostic test. A lot of women, when they do decide that they want this information, which I think is an important question to ask yourself when you're offered them, is, hey, is this information I want in my pregnancy? If you say yes to that, a lot of women will take the screening test route first, because it's a way to find out, hey, am I at high risk or low risk? Yeah. And if you're at high risk, then consider doing the amniocentesis. I've met obviously with a lot of women who are like, I need to know for sure, like I don't want any of that doubt. They'll go straight to a diagnostic test. And so that's why it's important to kind of understand what your options are early in pregnancy, so you can kind of start making those decisions with your healthcare provider.
Wow. Yeah, I guess I was still operating under the assumption that it was only women who were over 35 or had a family history of genetic diseases, but that's no longer the case. Any pregnant person?
It's not true. Any pregnant person.
Oh, how cool. How mainstream. Oh, I love it. So I was checking out your website. It looks like you have 3 main women's health offerings: family planning, prenatal testing, and hereditary cancer screening. So I'd like to walk through, especially the family planning and prenatal screening tests. So first, tell us a little bit about these pre-implantation tests that you offer. When would a woman need this? What's being tested? Kind of walk us through that.
Yeah, so I would say anyone who's considering pregnancy, I think the first thing to think about is carrier screening. So carrier screening is one of those tests that, I would say a patient and their partner should consider doing together, because typically what we're dealing with when we're talking about carrier screening are what we call autosomal recessive disorders. So if we think back to, 9th grade biology class for some people, you think about, you've got 2 copies of every gene in your body.
Got our little Punnett squares, y'all.
Yeah, those little squares. You got to do that. Remember all that fun stuff. So you've got 2 copies there. In most cases, for most genes, if you've got 1 working copy, that's enough, right, for your body to be like, I got this, right? Like I kind of know how to function. But when you're missing 2, right, you have 2 non-working copies, that's when you'll typically have signs of the disease. So what carrier testing does is it says, okay, you're healthy, right? Let's take a look and find out what you're a carrier for. Where do you have 1 copy that's not working so great? Because if you happen to decide to have a child with somebody who also has a non-working copy of that same gene, you are now at risk of having a child that could be affected with that disorder. So most people are familiar with like sickle cell disease or cystic fibrosis disease. These are diseases that follow that inheritance pattern. So there's carrier screening panels that are available now where you can screen from anywhere from 1 to close to 500 different genetic conditions to find out if you're a carrier and your reproductive partner are a carrier for any of those things. So I'd say for anybody who's considering pregnancy, that's a good place to start. kind of in preconception. Unfortunately, a lot of times people don't hear about carrier testing until they're pregnant, which again, still important information to have. But at that point, if you find out that you and your partner are both carriers for the same thing, we're back talking about amnios again, right? Because we're like, okay, you've got a risk now. Let's talk about diagnostic testing as a tool. Whereas if you're preconception, it can set you up for other options. So let's say you do carrier screening before you try to get pregnant. You find out that you and your partner are both carriers for cystic fibrosis. At that case, you could say, hey, maybe I want to look at IVF as an option. So you could consider doing in vitro fertilization. They can make those embryos for you in the laboratory at the IVF center. And what preimplantation genetic testing can do is allow us to develop a test that can actually screen those embryos before they're transferred to find out which ones do not carry those mutations, those non-working copies of those genes. So that's one of the tests that Natera offers is preimplantation genetic testing for single gene disorders. We also do preimplantation genetic testing for chromosome aneuploidy. So again, extra or missing chromosomes. So when you take that biopsy, a couple of cells like out of that embryo somewhere around day 5, again, we can screen for chromosome issues. If you know that you're at risk for a single gene disorder like cystic fibrosis, we can also develop a test to look for that as well. And the idea being is that you're transferring back the embryo that has the best chance, right, of becoming a healthy pregnancy. So that is one kind of area of our company. It's actually where we started. It was the very first test that we had when I started at Natera.
Fascinating. I mean, it's technically like test tube babies, right? But it's like optimized. And I think there's some genetic philosophizing here that you need to think about. I remember in college, I took an ethics class in terms of what is a genetic disease? And everyone was like, obviously cystic fibrosis, sickle cell. And then our professor, really amazing ethics professor at Drew University said, what if somebody found a gene that makes you gay? Like, let's just say, okay, what if somebody says that's a disease? And then what if you are screening for that and you're eliminating that gene because that person thinks it, and it was like, every day I went to that class being like, I know the answer to this prompt that he gave us, obviously. And every day I left being like, oh, we're so screwed, man. If we come up with this technology, there's some people out there who are going to like twist it, right? And so do you have any like experience with that? Or like, do you have to take classes like that?
Do.
Like, how do you select what's best for people? You know what I mean?
And we definitely had those classes in genetic counseling school as well. And I will say in experience, what you'll see too is I think one of the ones that sometimes people don't think about is something like achondroplasia. So achondroplasia is one of the common causes of dwarfing conditions, right? So it's one of the more common dwarfing conditions.
Yes.
And oftentimes, little people who have achondroplasia actually want a child that's similar to them, which I think totally
like the
makes
deaf
sense.
community as well.
Correct.
Yeah.
And so the question that you'll hear asked is, well, can they screen for the opposite? In that case, they're not screening for the child that would be expected to have, kind of typical stature. You're looking for one that's going to have a dwarfing condition. And is that okay? Right? Is the question that kind of gets asked in an ethical way. So technically, yeah, you can obviously screen in the other way as well. And so it does kind of open up a lot of these questions that get asked all the time. And to your point, there's really no one making those decisions, right? For anyone worldwide, I would say.
For better or worse, right? Because depending on who that person is, they can decide different things. Yeah. So interesting. We should get a bottle of wine and talk more about this because this is like so fascinating to me when you're like, what about? Now I'm off in
I know. And I know we were supposed to talk about some more testing. I know we were talking about more testing. We talked about preconception. We talked a little bit about NIPT, right? So NIPT is one of the main tests that people consider during the pregnancy. But like I said, people can also do carrier screening as part of pregnancy testing as well. If someone unfortunately experiences a miscarriage, during their pregnancy. We also have tests available to find out whether there was a chromosome abnormality that was responsible for that. So we can take tissue from that loss and we can analyze it, and we can see whether there was an extra missing chromosome or a piece of an extra missing chromosome. And many times that's actually what led to the loss, which can give people answers, because I think oftentimes when people go through a miscarriage, there's a lot of blaming, right, that can happen, where people are like, I did something, right? Like I did something wrong, something caused this to happen. And and about 50% of pregnancies are due, depending on when you have your loss, but can be due to a chromosome abnormality. So having that information that says, hey, this was there from the beginning. It was just a sporadic thing that happened. You didn't cause it to happen. And actually the chance of reoccurrence is actually very small in those cases. So it can be an answer a lot of times when there's not an answer. And so it can be helpful for people who go through that experience.
When you say you take a sample, like the woman has to bring in something maybe that from a home, or because
they can, yeah. There's, oftentimes, sometimes people know that they're experiencing a loss, so it may be something that happens at their doctor's office where the doctor can do that collection for them. Sometimes, obviously, these losses do happen at home. So as well, we have instructions, right, that we can provide people as to how to do that collection and send us back any tissue, right, that can be saved from that loss. But yeah, we have ways of kind of helping people and walk them through that process. Because
interesting. Yeah. And are any of these tests useful for the mother to know something about her own health? Because I feel like when we think about prenatal screening, some people may argue, oh, this is more like baby tech, right? It's about the baby's health. But talk to me. I have an assumption. I'm going to go on a limb here and gamble that it supports women's health as well. Can you tell me about that?
Yeah, so I think there's two places where you're looking specifically at women's health. One is, I would say, just with carrier screening in general, although the hypothesis going into carrier screening that you're healthy, right? Oftentimes we uncover things when we start looking, and we can find things. And I would say one of the things that commonly we will find is something like people who are carriers for Fragile X syndrome. So the reason we're screening for Fragile X is obviously to tell you the chance that you would have a child with that condition, which is one of the more common causes of male intellectual disability. But what can happen as a female is it can affect your reproductive, right? Like, can cause you to be at increased risk for premature ovarian insufficiency or failure. And so there are some health effects of being a carrier that can be important. So oftentimes, like I said, we will uncover, although maybe the goal was like you said, it's to find out stuff about the baby. We can uncover things that are important for the female as well, who's a carrier. And again, we see that a lot with X-linked disorders, meaning women, we've got two X's, one doesn't work, we've got the other one that compensates, but sometimes it doesn't compensate as well as we need it to, right? So you can see some health effects when you're a carrier of an X-linked disorder. So that would be one instance of it. The other one is the other product you mentioned, hereditary cancer testing. So hereditary cancer testing allows us to screen to see, hey, do you carry a change in one of these genes that predisposes you to cancer? Most of the genes that have been identified and are on hereditary cancer panels at this point are looking specifically at an increased risk for breast cancer, ovarian cancer, uterine cancer, colorectal cancer. So those are the genes that are on those panels. And so those are definitely things that I think are specific to women's health. Although obviously I would say men should be considering hereditary cancer testing as well. But it is one that specifically that we have available to kind of help people take control of that cancer risk, because there are things that you can do in many cases that can reduce your risk of developing cancer.
So you say that prenatal screening and testing has expanded beyond just high-risk groups to any pregnant human. What about the cancer screening? Do you need to meet some criteria in order to get that test done?
Yeah, that's a really great question. So for prenatal, yes, I think you've seen expansion, right? And that's been supported by the professional organizations as well, that's trying to get this out to as many people as possible. I think the goal is, again, to kind of diversify this and free it up, right? Like, these are important tests that people should be able to choose to have if they want them. So yes, on the prenatal screening part. On the hereditary cancer, there's a lot of people, I will say, who feel very firmly, specifically in regards to the breast cancer genes, that they feel that this should be available to everybody. At this time, there are some criteria, right, that I would say that most, insurers and payers are looking at, that's kind of based on the national cancer kind of guidelines. where they're saying, hey, did you have someone in your family who had breast cancer under the age of 50? Did you have someone with ovarian cancer? Did you have someone with pancreatic cancer? So there's like a list, right? We have a list on our website as well to kind of help people identify this, but there's a lot of these family history forms where you can kind of check, hey, do I meet criteria? And in the majority of cases, that means that your insurance company will typically pay for that testing. I think we're also trying to we believe strongly that people should be able to choose the genetic information that they want access to. So we try very hard to bring our cash pay price down. So if it's something like, hey, maybe I don't qualify, but this is important information and I really want it, we try to make that affordable if you want to cash pay and not go through insurance.
That's an interesting thing. We talk a lot with my founders about who's going to pay for this. And unfortunately, in women's health, oftentimes there is no billing code. And so let's add on another 3 years to your product development timeline. Correct. Because the government doesn't even recognize this as a thing, because there's no predecessor, there's no nothing. And these screening tests, specifically for these maternal health, the miscarriage, prenatal, how attractive is it to cover that for insurance versus covering a baby with illnesses? I would think that is the argument you give them to make sure they cover it, but is it still a battle to get them to cover it?
It is still a battle. I will say with a lot of the more common things like NIPT for Down syndrome and things like that is typically covered. You add on additional conditions. Like you said, you've got to prove that there's clinical value for the insurance company to deem this something that's going to be covered, or the government, right, to deem that it's something that should be covered. So it is a battle every time you kind of make an adjustment, right? Or have a new product that you're looking at is, hey, because we, spend a lot of time and put a lot of effort into studies, right? And clinical trials and things like that to show, one, that the test works, right? And it works as we say it does, but that it does do that, right? Like there should be value in these tests that we're providing to people. And to your point, early diagnosis, when you're talking about genetic disease, typically makes a very big difference when it comes to, I would say just the health and outcome, but also to your point, the cost to the healthcare system, if you can identify it early. Oftentimes, a lot of these disorders that you'll see on like our carrier screens or things like that may be rare. And unfortunately, people end up in quite a diagnostic odyssey, right? When they may have a child that has one of these conditions, because it's not easily diagnosed. And so it can take sometimes couples a very long time to get a diagnosis for their child that could have been, I would say, circumvented, right? If they had known early on that they were carriers and had testing early on to know that the baby was affected.
Yeah. So let's say a couple didn't do the pre-screening, they're pregnant, they get their test done, they find out my baby has this deadly disease. What do genetic counselors tell them? Do they tell them, abortion is, aborting that fetus is an option, or is it all about planning for the birth and how are you going to accommodate? Kind of walk us through that hard part, the part that that's the part that you saw.
Yeah, the part that you saw in person. Yeah, and it is hard. And I would say, given current, news headlines, I think it's looking like it's going to get a little bit harder.
Yeah.
I think for everybody who works in this area, counselors are trying to provide choices to people. Right. So feel very strongly that everybody should make decisions that are in line with their personal values and what they want. Right. And so you'll see that counselors are extremely non-directive typically in that way, but we do feel very strongly that people should have options in front of them. So that conversation that a counselor has with a couple when they're faced with a diagnosis like that does vary. Right. So the counselor's training is to be like, tell me, right, like where you are in this, because my goal is to help you make an informed decision about what you want to do next. So yes, for many couples that may be, depending on where they are in pregnancy, it may be discussing a termination of the pregnancy. For others, it may be, I need to get you connected with some people locally who have a child with this condition. Right. So you can prepare for what that means. It also may mean, we know that this baby may have heart problems, right? So I'm going to get you in, right, and make sure that you meet with a cardiologist, right? So we make sure that we have the right healthcare lined up for when this baby is born, that you have the right people at the hospital, that you deliver at the right hospital, right? It may be important for somebody who's in a more rural area, if they find out their baby has one of these conditions, that they need to be somewhere that has the right doctors on staff to care for that baby when it's born. So a lot of times it is a preparation conversation. But again, that's going to be really dependent on the couple, right? How they're processing. Oftentimes there's many conversations, right, that are going to happen after this. As you saw, like, breaking bad news is not a one-time deal, right? Like a lot of people will shut down, which I think is natural, right? When you hear something like that. And so it is something that the counselors are trained to be like, let's talk again. Let's talk again, right? We're going to keep kind of getting and kind of working with the couple to get them where they want to go.
Mm-hmm. In light of Roe versus Wade, and, and I'm not bringing this up, listeners, if you want to learn more about abortion, we have those episodes, but just in the terms of this conversation, how do you think the Roe versus Wade going away could affect how genetic counselors advise their patients?
I think it's going to make it very hard. I mean, like I said, I live in Texas, so we're already kind of limited to a certain degree in what people have access to in the state of Texas. I will say that in the past, I would say, let's say 20 years ago when I was practicing, it wasn't uncommon for me to talk about, okay, you may need to look at it in another state, right? If this is something that you want to do. I think that looking at the headlines right now, I know that most counselors are looking at that going, okay, what do I think my state's going to do? And what's the state closest to me going to do? And what are my options there if a patient needs that, right? And decides to go that route, what are we looking at? So I would say that's the type of conversations that are probably realistic. I have to say, in Texas, the law is extremely interesting. And any aiding and abetting, right, can put you at risk.
Aiding and abetting as a genetic counselor. Oh my gosh. Yep. Oh God.
So it does make things extremely difficult, right? Because again, at the end of the day, all the counselor wants to do.
You're thinking about your own butt too. Not only the
so now
woman's
it's made it tricky as to what you feel like you can really do. Where our training is, look, I just want to help this couple, right? I'm trying to get this couple what they need. And what's best for them. So it does make it more complicated. So I think it's going to make it harder on counselors. It's going to be harder.
I have two more quick questions about the abortion thing and how it relates to this, just because I think the medical side of it is so fascinating, regardless of pro-choice or whatever, like just healthcare. Can you identify a lot of these abnormalities before 6 weeks of pregnancy? Or is there literally like you have to wait till certain weeks of pregnancy to even find these things out?
It's really, you have to wait. So even with the screening tools that we provide, like typically you need to be at least 9 weeks, closer to 10, in some cases closer to 10 for certain tests, in order to even run the screening test. And like I said, the screening test is not diagnostic. So it's really only telling you that you're at high risk. God forbid anybody, and we're very clear as counselors, right, who counsel on these tests all the time, that you should not make irreversible decisions based on a screening test. Like you really need to be doing a diagnostic test, but that does extend the timeline to your point, right? Like amnio can't be done until 15 weeks of pregnancy. And so you're typically not finding this information out until you're well into your second trimester of pregnancy. And so, I mean, just on a personal note, I find it frightening, right? That this is where we're heading, because there's a lot of headlines about, I don't think they understand this part of it.
No, of course they don't. Of course they don't. And my one last question about abortion is, I've heard that they can criminalize potential miscarriages in the hospital, in the ER room, because if they suspect that you actually tried to do an abortion, there could be homicide charges. And so could a screening test for the potential cause of that miscarriage might help here? I mean, it's preposterous, but if this is our reality, we got to come up.
I think it's an interesting question. So, I mean, I would argue at that point, like, does that push the the issue of, let's make sure we understand what caused this, this
before somebody says, oh, she tried to do an abortion, like potentially there could be a miscarriage test with the sample that then you show.
I mean, it would, my fear would be then the flip of it is if you don't,
if they didn't have it, that's right.
Like, then what is that, does that help people? But in general, I think that, for most situations, having more information does help.
Thanks so much for going down that rabbit hole with me and my listeners. I think that we'd all really benefited from that and have armed ourselves with some more arguments for our upcoming debates in our own communities. which is a reminder for y'all to vote locally, because if it's up to the states, it's your vote in your community that is going to depend, essentially predict women's health in your community. So Jennifer, is there more need for innovation in genetic testing for women's health? What are some areas in genetic testing, maternal oncology, what have you? What are some tests that you wish were out there? Where else can we innovate in this?
Yeah, for sure. And I would say, I know specifically talking to your audience, I would love to see more female-led driven technology companies in this space because I find that oftentimes they're still run by men these days, right? And I feel like we do play a big part of that as counselors, saying, hey, right? Like I said, being the patient advocate, but also as females, right? You should be listening to us. We're also the consumers here. So I would love to see, right, more companies that are kind of founded and started and run by females. So they can push forward that. Genetics is the reason I got into it. It's ever changing. There's so much potential. It's hard to even name one area. I think that you're seeing a lot of growth in just the number of things that we can look at. And I think a lot of that's being driven now by the fact that it used to be very expensive to sequence a gene, right? You think back 15 years, Myriad had a quote unquote patent, right, on BRCA1 and 2, and they were charging $3,000 to $4,000 for that test. The sequencing tools have gotten so much better these days that it's brought down the cost of the testing. It's allowed us to add more genes in there. So it's a lot easier, right, for everybody to do the system. And also you can't patent genes. So thank you. It's allowed us, right, to really spur, right, a lot of new genetic tests and new players in that space. So I think there's going to be more need for, again, I would say even one example, we have a new product at Natera that's specifically looking at renal genetics. So renal genetics is one of those things that when you went down the list of things that the spaces that counselors worked in, if you looked at that 5 years ago, I don't think anyone would have said renal genetics. But it's a huge new area, right, where we're looking at, hey, there's a lot of people who have end-stage renal disease that actually have a genetic cause, right? So I think typically what you've seen in genetics is this thought of thinking about kids with genetic diseases, right? Or cancer specifically, but now we're realizing, hey, no, there's a lot of conditions like this that may not pop up until much, much later that still have a genetic component to that. And that's a whole new area that's just popped up in the last couple of years. So I would say pick your favorite organ, right? And there's all sorts of potential. We've seen a lot of growth in the last 10 years in cardiology, right? Specifically, so cardiac genetics. So you're seeing a lot of these things come through. I also think there's going to be the innovation in how you really give patients access to their information, both the genetic test that gets relayed to them, but how that changes over time. I'd say it's the struggle that all the laboratories are having right now regarding, hey, this may change. We learn new stuff about these genes all the time, right? And so we have to have resources to kind of stay up on that. But the bigger question is, how do we get back in touch with people, right? So the technology to even do something like that, how do we maintain contact? How do we contact? Because a lot of times, especially for an OB, right? They go in, they do the pregnancy, they leave, right? They may have their hereditary cancer test through their OB-GYN, but then they move, right? So the question is, how do I let them know if something changed, right, in their genetic test results? So I think there's a lot of even side tech, do you know what I'm saying? That's not even, I would say, a genetic test, but how you maintain this data, how you share it with patients, how you make sure patients understand what they're getting, what they're not getting, what their raw data means. We get a lot of patients, right, who did some consumer testing.
Oh, yeah.
And they go, hey, I want my raw data. And I was like, whoa, really? Why? What are you going to do with it?
I know. Yeah. Oh boy. Yes. I know you so much because my first startup was a DNA-based dating app and a lot of people wanted their raw data. And I was like, we can send it to you, but you're not going to know what the hell it's talking about.
Yeah. So but I think that's where it's showing these areas, right, where no one's really figured out the path forward yet.
Yeah.
I think there's a lot of opportunity all around.
So much opportunity. Because I think that also technology sometimes is, the goal is to remove the human component, but it's so important in this case to maintain a human component.
Yes.
Because, you know, even if we quote unquote dumb it down to you have cancer or, you know, predisposed, like there's ethics behind just emailing somebody that with a subject line, like you're positive for cancer, right? Like we have to think about like how and when do we tell people and things like that, right? Yeah.
Absolutely. And there's a lot of, I mean, we're looking at it, a lot of laboratories are using, you know, chatbots and things these days, right? We've been very careful internally, like all of our chatbots are trained by genetic counselors, right? Because we want to your point, no one wants to open an email that says, surprise, right? Like you're at increased risk for cancer.
Yeah.
So we want to be very careful on how we're relaying this information in a way that doesn't come across too disconcerting, but obviously relays the seriousness of it as well, right? And then we want to play catch, right? So we understand, obviously, as this goes out to more people, we're probably not going to be able to have a genetic counselor speak to every single patient, right? That's out there, but we do want to be available for people who have more questions. Right. So I would say too, if you're a person who's thinking about any of these tests, reach out to the lab and see if they have a counselor on staff, because that's what we're here for, right? Like we want to make sure people know what they're getting, right? And that they understand it properly and understand what their options are next. So I'm glad to see that a lot of genetic testing companies do employ a lot of counselors, because I think that it's important to provide that level of service to both patients and healthcare providers. Mm-hmm.
Jennifer, this has been such a rock star interview. I am buzzing. I want to talk to you the rest of the day, but we got to cut it. And so I'm going to thank you for your time.
Oh, thank you.
So informative. Thank you so much.
My pleasure.
All right. I just ended the audio. So good. And I genuinely mean that. Like, these are women's health, genetics. All we needed is bacteria. And I mean, you got me. Like, those are my favorite topics. I interviewed a founder of a vaginal microbiome sequencing company, and I was like, "You're my girl." Like,
you're geeking out, right? Yeah, exactly.
I'm like, watch the clock, Bray, watch the clock. And so let me just save this really fast. Natera interview. Cool. All right. So the last thing we like to ask is to just get your voice on recording, introducing yourself, saying your name, your title, the company, and then saying Femtech to me is. And a lot of people will give a definition or a statement that's kind of similar to the work they do. So for yours, I could imagine it sounding something like Femtech to me is providing, you know, prenatal screening and hereditary testing for women to make the best choices for their bodies and families, or something like that. I usually say, like, it's something you usually probably say a lot, like your own little tagline is usually what is a great thing to say for this. So
that sounds good. Yeah.
Are you ready? Do you know what you want to say?
I'll wing it. Let me think about it. Yeah, I think I'm going to wing it. We'll see. We can obviously re-record it.
I have so many bloopers. Don't worry. I don't know what I'll do with them one day, but you're more than fine to do it several times. So
yeah. So Femtech means, so it's let me make sure I get the
Hi, I'm Jennifer. Mm-hmm. My position at Natera. Femtech to me is. By the way, where are you calling me from today?
Oh, I'm outside Houston. Yeah.
Oh, cool. I lived in Montrose for about 8 years. I did my PhD at BCM. Yeah.
Very nice. We actually work very closely with Baylor, the genetics laboratory. So that we
good. Yeah, you probably, Richard Gibbs and all those people. Yeah.
I've heard those names. Yeah.
Yeah. Cool. Interesting. Well, I moved to Raleigh during the pandemic. I made a pandemic move. Nice. I was tired of living in the city, and I was like, I need trees and seasons.
Oh, I hear you. Well, that's why I'm north. Yeah, I live up in the woodlands. So I'm just hiding in the woods, right?
All right, cool. So we'll just be quiet for a second, and whenever you're ready, you can go for it.
Hi, I'm Jennifer Saucier, Senior Director of Clinical Genetic Services at Natera. Femtech to me is giving women access to the latest genetic information to manage their pregnancies and their risk for hereditary cancer.
You don't even need a blooper.
We'll go with
it.
It'll work.
Perfect. All right, cool. And I think we didn't acknowledge the other person in this room, but hi Azim.
Oh yeah, don't mind me.
We didn't, obviously, we just kind of went right through it. Thanks for being here. What did you think about the interview?
No, I think it was great. I think it was great, and I think Jennifer obviously did very well, and yeah, I mean, no comments from me. I think it'll be a good episode.
Great, I agree. I am pulling up my calendar here so I can tell you exactly what day it'll drop. Just give me 1 second. All right. So technically I have, oh my goodness, I have so many scheduled things here. 25. So it's actually scheduled for August 1st.
Great.
Yeah, because we post every Monday. So on August 1st, I'll email you that morning with the link saying, hey, your podcast episode's live. Here's the links. And then you share it, we'll share it, all that stuff. It goes in our newsletter. We post it in our virtual community. We post it on our social. So we'll promote it that way. And if that date changes, I'll let you know if any, my other episodes maybe get rearranged, but it looks like August 1st.
Yeah, and if there's any hashtags or anything you want us to use, just let us know. We'll be sure to do that.
Yeah, I will. Yep. In the email I send you, it'll have that in there. Oh, look at that. Actually, I have a rockstar intern who actually already put you in the schedule. So I was going to add you to the bottom. Turns out you're actually scheduled for July 4th.
Hey.
Oh.
Yeah.
My birthday's the 5th. It's my birthday present.
My birthday's July 5th.
Is it really?
Yeah. I knew
that.
it. We were just little Cancer sisters.
Cancers together.
Yeah.
Exactly.
Yeah. Cool. That actually is not a bad date because we find that we actually have increased listeners during the holidays because a lot of people listen to this while they travel. So it's actually a great holiday to have it on. So yeah, so July 4th. I'll email you then.
Fantastic.
Cool. All right. This has been wonderful. Thank you so much. I'll talk to you soon.
Thanks, Brittany.
Bye.
Have a good one.
Bye.